All right, in just a second, I'll get started. So welcome to our panel. Today's panel is called Brain Health Literacy in Midlife, a Research Agenda. I'll just give a little bit of a brief overview for this talk. Um, so today's panel session is going to introduce a novel research agenda that focuses on midlife determinants of later life cognitive, physical, and emotional health and well-being. So our whole team here is from Northwestern University, the Feinberg School of Medicine. We're all embedded within the Center for Applied Health Research on Aging, or CARA, which is directed by Dr. Mike Wolf. Our team has been working on an ongoing NIA-funded longitudinal study of older adults called LitCog, which focuses on understanding the impact of health literacy, self-management skills, and healthcare engagement on later life risk for outcomes related to chronic disease, mental health, and cognitive health. And we actually recently initiated a parallel cohort of middle-aged adults, so between the ages of 35 and 64, allowing us to take more of an adult life course perspective related to all of these same factors. So the inclusion of middle age is pretty uncommon for cognitive aging studies, but there has been a recent movement to focus on more of the earlier stages of the life course. And this move really aligns with several calls to action. So the NIA strategic directions for research highlights the importance of looking into pathways by which social, psychological, economic, and behavioral factors affect health in both middle-aged and older adults. And then in May of this year, the National Academies of Science, Engineering, and Medicine report also concluded that there's this pressing need to address brain health trajectories earlier in the life course, and also to achieve greater diversity in studies. So the aims of MidCog include exploring associations between health literacy, self-management skills, health status, and the presence and management of chronic disease, and then cognitive function among middle-aged and older adults, and also to investigate associations between these factors and healthcare use and health status, and then also to examine potential moderating factors, so things like health activation, treatment burden, and social support. So today's presentation will discuss some of the work that our team has done thus far, looking into some of these factors. So to introduce our panelists, first up, we'll have Abby Vogley, who is a second-year clinical psychology doctoral student at Northwestern in the Feinberg School of Medicine. She's working in CARA under the mentorship of Dr. Wolf, and her area of emphasis is in neuropsychology. Her specific interests are in the assessment of cognition, cognitive impairment, and health outcomes across the lifespan. And then we'll hear from Brittany, who is a research coordinator in CARA, and she received her bachelor's degree from Washington University in St. Louis, and she's currently applying for medical school. And her specific interests are in community-centered intervention to promote health equity. And then I will actually be the final panelist today. So I'm Sophia. I'm a clinical psychology doctoral student and candidate at Northwestern Feinberg School of Medicine as well. I'm currently on my clinical internship at University of Chicago, and my area of emphasis is in health psychology or behavioral medicine. And a lot of the work that I will be presenting today is from my dissertation that I've defended this year. So for our agenda, Abby will first provide more of an intro into our MidCog study, and then she'll present on data on the relationship between health literacy and self-management skills in middle-aged adults. Then Brittany will discuss social determinants of health and structural factors in midlife and their associations with cognitive, physical, and emotional health outcomes. And then we'll introduce a brain health literacy framework focusing on midlife and with a health equity approach. And we'll present some preliminary data on related findings. And then finally, we will open it up for Q&A. So I will go ahead and pass it over to Abby.
All right, thank you so much, Sophia, for that lovely introduction. Let me just quickly, let's see. All right, looks like I have control of the screen. Okay, great. So yeah, my name is Abby Bogley. I'm a doctoral student in Dr. Michael Wolf's lab, and today I'll be presenting on the prevalence of limited health literacy and associations with self-care capacity in middle age, results from the MidCog study. All right, so I first just wanted to briefly discuss why study health literacy in midlife. So over the past 3 decades, extensive research has illuminated the substantial impacts that health literacy has on our overall health and well-being. And there's substantial correlations between inadequate health literacy and various negative cognitive and also psychosocial outcomes. These can include worse health knowledge, lower uptake of productive health behaviors, higher engagement in risk behaviors, and chronic disease outcomes. Now, most of the foundational research in this field has predominantly focused on older adults or those aged 65 and older. And this focus is understandable given that older adults often do have higher healthcare needs. However, this does leave a considerable gap in understanding how health literacy impacts those particularly in midlife, particularly among individuals who might benefit from effective health management. So in older adulthood, our research and others have repeatedly shown how cognitive function, socioeconomic position, and other factors act as major determinants of health literacy in later life. And in turn, health literacy is thought to impact outcomes through 3 primary pathways. And these are described by Pash, Orlow, and Wolf in their conceptual model. So these 3 pathways include how one accesses and uses healthcare services, how they interact with healthcare providers, and how they self-manage health conditions while maintaining a healthy lifestyle. So together we call this healthcare activation. And a crucial component that I'd like to focus on today is health self-management. So we define this as one's ability to take charge of their health on a more personal level. And this includes essential skills such as properly dosing out medication, refilling prescriptions on time, interpreting health information given by physicians, and then finally managing daily symptoms related to their chronic conditions. And we've seen through our research that one's health literacy skills in later life impacts one's health self-management and in turn, their health outcomes. So when thinking about how this might translate to health in midlife, we posited that one's health literacy skills in these formative years may similarly impact health outcomes and in turn later life cognitive function. And additional factors that arise during this crucial life period make investigating this specific time frame separate, distinct from later life, highly informative. So during midlife, there's numerous factors associated with poorer health outcomes that begin to surface. A really big one that we focus on is the onset of chronic conditions. And this begins to develop and can impact cognitive function and then subsequent personal health. There's been some reports that about half of adults in the United States manage at least one chronic condition, with about a third dealing with multiple chronic conditions. However, they may be delayed in their detection or poorly managed due to poor treatment adherence, whether intentional or unintentional. In addition, sensory impairments, such as reduced vision acuity or hearing, also tend to appear around this time, and also some may not be attended to properly. And then finally, midlife is a time of significant stress. There's many stressors that come up, such as learning to manage these chronic conditions, caregiving responsibilities of both children, parents, and sometimes even grandparents, financial concerns with financial instability and financial burdens arising, and then navigating life stressors such as divorce, marriage, children changes, and retirement. So when looking at the ways to manage one's health in midlife, it is crucial that we better understand if one's baseline health literacy may impact their abilities similarly in later life, and whether this provides an entry point for earlier intervention. So, while the positive relationship between health literacy and health self-management has been extensively studied in older adults, the research in middle-aged adults remains pretty sparse. Of the existing studies, a lot looking at health self-management specifically tend to utilize self-report questionnaires, and these aim more so at how the individual is perceiving their management of specific chronic conditions. However, for those self-reported measures, they might not always provide an accurate reflection of an individual's actual self-management abilities across a broader range of chronic conditions. So to address this gap, we believed that by using a more objective, standardized measure of health self-management in a primary care middle-aged sample, we could better generate findings that might be more applicable to a broader midlife population that is managing multiple chronic conditions at one time. All right. So for this study, our research aims to achieve three primary goals. So the first one is to determine prevalence of low health literacy in a middle-aged cohort. The second is to characterize the socio-demographic factors associated with low health literacy. And the third is to investigate the relationship between health literacy and self-management abilities. So as Sophia mentioned, we are a part of the MidCog study. So just to briefly go over it, the MidCog study is a longitudinal cohort study. We began in 2022, and we're actively wrapping up the recruitment of our first cohort. These participants are midlife adults, age range from 35 to 64, and they're primary care patients at one of 12 federally qualified health centers or an academic general internal medicine ambulatory care clinic in the greater Chicagoland area. And eligible participants were English speaking and also active participants or active patients at their primary care clinics. And they consented to two structured interviews. So the first one is a 2.5 hour long in-person interview, and then a phone interview that's conducted for about an hour. Additionally, we also collected medical history through their electronic health record, and we also were able to collect 2 weeks of sleep data through an actigraphy watch and manual sleep diary. All right, so through these assessments, we were able to capture a wealth of information. This included basic demographics such as sex, gender, race, ethnicity, and occupation, social determinants of health, including socioeconomic status, work status, educational attainment, and healthcare access, health status, which included the number of chronic conditions and medications participants were managing at the time, cognitive and physical function, and this was both through self-report as well as objective measures, mental health status, which included a self-report, some clinical outcomes, including number of hospitalizations. And finally, for my talk today, we were able to assess health literacy and health self-management. So for our analysis, we concentrated on health literacy as the independent variable, and that was measured by the newest vital sign, or the NVS, and then health self-management as a dependent variable assessed using the Comprehensive Health Activity Scale, or the CHAS. Now, because this is a health literacy conference, I won't go too much into the NVS, but briefly, it's a 6-item health literacy screener, and it evaluates participants' interpretation of a nutrition label. Based on their performance, we categorized our sample into 3 groups: low, limited, and adequate. All right. And then to assess for health self-management, we utilized the short comprehensive health activity scale, which was implemented in our older adult LitCog study. And this is a 16-item assessment that has questions that focus on understanding printed health information, recalling spoken health information at both immediate and delayed intervals, and then accurately dosing medications based on labels. The total CHAS score and the 3 subscores, which were print comprehension, spoken recall, and medication dosing, were all standardized on a scale score of 0 to 100, with higher scores indicating better self-management skills. All right, so moving into our results for this analysis, we used 683 of our middle-aged primary care patients. So of our cohort, about 2/3 were assigned female at birth with an average of age of 52 years old. And in terms of racial and ethnic diversity, about 40% identified as non-Hispanic Black, 34% as non-Hispanic White, and 17% as Hispanic or Latino. Of note, though our sample might not fully reflect the current racial demographics of Chicago, it does include a significant proportion of individuals from historically underrepresented groups in this kind of research, and we hope to continue to expand upon this in our continuing recruitment. So on average, our participants were managing 2 chronic conditions, and they were also taking about 5 prescription medications. In addition, about 60% of the participants held a college degree, 2/3 were employed or working for pay, and 2/3 reported an annual income exceeding $50,000. All right, so to go on to our first aim, determining the prevalence of low health literacy in our middle-aged cohort. So according to the NVS, we found that about 1 in 7 presented with low health literacy, and 1 in 5 were likely to have limited health literacy. So collectively, this means in our cohort of health-seeking middle-aged adults, about 1/3 of our sample demonstrated inadequate health literacy skills. All right, so then going on to our second aim, we wanted to look at the socio-demographic factors associated with low health literacy. So we discovered that compared to individuals with adequate health literacy, those with low health literacy were more likely to identify as non-Hispanic Black or Hispanic or Latino, have obtained a high school education or less, possess a lower income annually, and to have a lower score on a cognitive screener and to be unemployed or not working for pay. Additionally, we also found that individuals with low health literacy reported managing a greater number of chronic conditions and prescription medications. And of note, they were also more likely to manage chronic conditions such as arthritis, diabetes, or congestive heart failure. All right, and then moving on to our final aim, we wanted to look at the relationship between health literacy and self-management abilities. So our analysis revealed that compared to those with adequate health literacy, the individuals with low and limited health literacy performed significantly worse on health self-management tasks. And this trend persisted even after adjusting for confounding variables, including age, race, education, income, and number of chronic conditions. Similarly, when looking at these individual subscales, medication dosing, spoken recall, and printed comprehension, we can see this same stepwise trend, where those with low and limited health literacy performed worse on these health self-management tasks compared to those with adequate health literacy by a significant amount. All right, so moving on to our conclusions. Our results suggest that a significant proportion of our middle-aged primary care sample, many of whom are managing multiple chronic conditions, demonstrated low or limited health literacy, and this equates to what we found in our later life samples as well. And of note, most of the sociodemographic factors associated with the poorer health literacy are linked to existing health disparities within under-resourced and minoritized communities. So addressing these disparities is essential not only to improve individual health outcomes, but also just in general to promote equity in healthcare access and quality. And then some implications. So this prevalence and its impact on self-management also aligns with our past research of older adults. And this really just highlights a critical gap in health literacy research, particularly concerning midlife populations managing multiple chronic conditions. And this gap actually provides an opportunity for more targeted interventions aimed at improving both health literacy and self-management skills during this crucial life stage. This might show as a renewed focus on health literacy as a potentially modifiable factor to promote health patient engagement and health promotion through things like patient education and skills training, but also through improved organizational health literacy that simplifies patient roles and demands. So if anything, just thinking about health literacy as a path to prevention and working with middle-aged adults before chronic conditions get too severe or overwhelming to better implement these health practices into their daily lives. All right, with that, I will hand it over to Brittany. Thank you so much. And thank you so much to the MidCog study team and Dr. Wolf for this opportunity.
Well, thank you so much for starting us off with that lovely talk, Abby. So we're going to continue in this theme of our study. So today I will be speaking to you about neighborhood deprivation and health outcomes among middle-aged primary care patients in our MidCog cohort. My name is Brittany. I'm a research coordinator in our lab at the Center for Applied Health Research on Aging, and I'm excited to get to talk about this today. So as Abby briefly mentioned, midlife is an important period of time and a critical period of time for various interventions. It's a period where things like work stressors, caregiving and family responsibilities, and just general life stressors, whether that be financial, things happening around a patient, all of those combine to create a particularly unique blend of factors to consider for those living in midlife. In addition, midlife is often where many chronic conditions develop or are diagnosed or are beginning to be managed. So things like high cholesterol or hypertension or diabetes are different chronic conditions that our patients in midlife are beginning to contend with. And so all of these are different avenues for where social determinants of health may come into play. So according to Healthy People 2030, the social determinants of health are the conditions in the environments where people are born, live, learn, work, play, worship, and age. So in other words, spend any amount of time. So those different environments and those conditions that affect a wide range of health, functioning, and quality of life outcomes and risks. So more broadly, it's about the different non-medical factors that do end up impacting people's health. In particular, Healthy People 2030 separates the social determinants of health into these 5 different categories. They include education access and quality, healthcare and quality, neighborhood and built environment, social and community context, and economic stability. And so these various factors fall into these 5 different categories. And as we mentioned about midlife before, you can see how these different factors may come into play, especially in midlife. So today, I wanted to focus on the intersection of 2 in particular. So it's neighborhood and built environment and social and community context. So more broadly, with the intersection of these 2 categories being the idea of the environment around a patient, of the context that they're living in, that might impact their health in ways that are not currently captured. And the way that I'm going to approach that today is through looking at something called neighborhood deprivation, or a measure of the socioeconomic disadvantage of the neighborhood that a patient resides in. And I'm going to capture this using the Area Deprivation Index, which I will go into in a little bit more detail shortly. But this is thinking, therefore, on a more structural level and looking outside of just individual level social determinants of health and those socio-demographic factors, but also into the environment around a patient. So my objective for today's study is to investigate the association between neighborhood deprivation and self-reported health outcomes in middle-aged adults, and also to determine if health literacy moderates these associations. So in terms of our sample, Abby did a fantastic job of explaining the MidCog cohort and MidCog study protocol. But just as a little recap, this is an interim analysis of the MidCog cohort, which we are currently finishing up recruitment for. And so my sample today includes 901 patients recruited from 2 different ambulatory health centers in Chicago, 1 academic general internal medicine practice, and 1 community health network of federally qualified health centers. For patients to be included, they must be English speaking, ages 35 to 64 at enrollment, possess adequate vision and hearing, have no severe cognitive impairment, and they must also receive primary care at an enrollment site. And then going into our measures, so the Area Deprivation Index was the measure chosen to represent neighborhood deprivation. So the Area Deprivation Index, or the ADI, comes out of Dr. Amy Kine's group at the University of Wisconsin and their work on the Neighborhood Atlas. The ADI is an area-level measure of neighborhood socioeconomic disadvantage, and it is a composite index that uses 17 different census indicators of poverty, education, housing, income, and employment. So for example, the ADI uses the American Community Survey 5-year estimates of things like the percentage of population with less than 9 years of education to get at the education factor, or the median family income in a neighborhood to get at the income factor. They also might look at things like median home value to get at the housing factor, and these various different indicators. The ADI is measured at the census block group level. The census block group is the smallest level of granularity that the census and the American Community Survey captures data at. In general, the census block group is probably the closest approximation to a small neighborhood that we have for our patients. The census block groups generally contain anywhere from about 600 to 3,000 individuals, so pretty granular and able to zoom in a little bit more than different area measures such as zip code or census block in general. So in the way that we use the ADI in our analysis here is that we captured the national rank of a participant's neighborhood of their census block group using their residential address. And so these national ranks rank all the neighborhoods, all the census block groups in the nation, and assign them percentile ranks. So we gathered that percentile rank for each neighborhood and then split it into terciles within our cohort with our 3 different terciles. So we had our lowest tercile, which indicates our least deprived neighborhoods, our intermediate tercile, which indicates intermediately deprived neighborhoods, and then our highest tercile, which indicates the most deprived neighborhoods. And just a little visualization of what ADI might look like, this is a graphic that shows the range of the ADI in Chicago. So as Abby mentioned, the MidCog study does take place in the Chicagoland area, and so most of our patients are drawn from the greater Chicagoland area. This does extend all the way into Indiana, which this map doesn't show, and we do have participants who come from even outside of that area, but the vast majority of our patients are from the Chicagoland area. And on this map, you can see that the blue colors with the darkest blue colors showing the least disadvantaged block groups, and the reddish colors with the darkest red showing the most disadvantaged block groups. So within this, you can see that there is some diversity in ADI within the Chicagoland area. You'll also notice the economic segregation that is so apparent in Chicago and in many other cities, where neighborhoods to the south and west of the city tend to be more disadvantaged than those in the center and north parts of the city. So this is just a view of what kind of the diversity of ADI might look like, even within one metropolitan area. And then in terms of our other measures, we use the newest vital sign, or NVS, as a health literacy measure. The screening for health literacy separated our participants into those with adequate, low, or limited levels of health literacy. And then in terms of our outcome measures, we looked at 5 different outcomes of health outcomes for our patients. So 4 of these were promise reported outcomes. So those are the patient reported outcomes measurement information system measures. So that's self-reported measures, and using their T-scores to determine if these patients have self-reported poor physical function or fatigue or anxiety or depression. And so those are all our promise patient reported measures. And then our 5th outcome, cognitive impairment, was determined by using the Montreal Cognitive Assessment, or MoCA. And so a MoCA score of less than 23 was assigned as being cognitively impaired. In terms of our analyses, all analyses were conducted in R. We used the Kruskal-Wallis test for continuous variables and the Pearson's chi-squared test for categorical variables. We conducted first a logistic regression to determine the odds ratio for the odds of a poorer health outcome, but comparing the most deprived tercile neighborhoods to the least deprived tercile neighborhoods. And then we conducted a multivariate logistic regression that included the a priori covariates of age, sex, and number of chronic conditions for all outcomes. We also included the covariate of education for our cognitive impairment outcome. We also conducted a moderation analysis to see if health literacy moderated the association between neighborhood deprivation and these various health outcomes. So moving into our results, here you will see a table of patient characteristics by ADI tercile. So our terciles, once again, were separated into lowest, intermediate, and highest, with the lowest tercile indicating those patients coming from the least deprived neighborhoods and the highest tercile indicating those coming from the most deprived neighborhoods. So you'll see just overall, our cohort does tend to come from neighborhoods that are less deprived. We had a median ADI national rank of 36 within our cohort. So on a scale of 1 to 100 in that national rank, 36 is definitely showing that our participants in general come from less deprived neighborhoods. Going into our terciles, those coming from the least deprived neighborhood had an ADI national rank median of 15, whereas those coming from the most deprived tercile neighborhoods had an ADI national rank median of 74. Just to note is that our participants did come from neighborhoods that span the entirety of the ADI national rank, so from 1 to 100. So that does provide some diversity in terms of the area deprivation index in our cohort. In addition, you can see that our cohort overall had a mean age of 52. 59% of our cohort identified as female sex, and 20% of our cohort reported an annual household income of less than $25,000. So looking at how these various covariates might be associated with ADI tercile, you'll see that compared to those living in the least deprived tercile, those living in the most deprived tercile were significantly more likely to be younger, of female sex, and also have a lower annual household income. And then continuing this table is patient characteristics continued by ADI tercile. So 55% of our cohort had 2 or more chronic conditions, and 64% of our cohort had a college degree or greater in terms of education. And you'll note that those living in the most deprived tercile were more likely to report having 2 or more chronic conditions, and also were less likely to report being a college graduate or having additional education beyond that. So moving on to the results from our regressions, you'll see on the left side of the table are our odds ratios from our initial logistic regression, and on the right side of the table are our results from our adjusted multivariate logistic regression. Upon our first logistic regression, we found that living in the most deprived neighborhoods versus the least deprived neighborhoods, for those participants, they had greater odds of experiencing depression, poor physical function, fatigue, and also cognitive impairment. After adjusting for age, sex, and number of chronic conditions, and then also for education for our cognitive impairment outcome, we found that those living in the most deprived tercile neighborhoods compared to the least deprived tercile of neighborhoods were likely experience greater odds of experiencing poor physical function, fatigue, and cognitive impairment. And then in terms of our moderation analyses, we found that health literacy did not moderate any of these associations. So in summary, neighborhood deprivation was associated with physical function, cognitive impairment, and fatigue, but not with the mental health/emotional outcomes of anxiety or depression. I'm thinking about limitations and future directions for our study. A few limitations include that our study is currently enrolling for our first time point, so it is currently cross-sectional, but as we enroll more participants and also as we hope to start our second wave of interviews next year, hopefully we'll be able to conduct some longitudinal analyses in the future. In addition, our study, it does pull predominantly from one metropolitan area. So while Chicago is a pretty diverse city, we don't know how this might extrapolate to the United States as a whole or other cities around the world. And then in terms of future directions, this analysis used the ADI, which is a composite index. So the composite index can be helpful in that we are gathering a general view of neighborhood deprivation and of what a patient's community and social context around them, how that might impact their health. But what it lacks is a little bit of specificity. So in terms of looking at what specific parts of a neighborhood drive these associations, we could look into if it's more housing or income, employment, any of those different factors that might have gone into the ADI, if any of those in particular are driving these associations. And then in terms of implications and importance, and if we're thinking about working towards health equity in general, this sort of analysis and a greater body of research that has linked the ADI to poorer health outcomes indicates that we do need to consider a patient's neighborhood context when considering their health. So one innovation in the sphere includes the Center for Medicare and Medicaid Services ECHO REACH model. So in their accountable care organizations, at certain accountable care organizations, they started to implement a health equity benchmark adjustment that uses the ADI. So in so doing, that increases money going to beneficiaries in areas of higher ADI to better support disadvantaged communities. And so that represents a possible pathway for intervening at the neighborhood level and in looking at things like the ADI. And then just thinking about health literacy in a larger context, in this analysis, we found that health literacy did not moderate the association between neighborhood deprivation and health outcomes. So that is intriguing, and that we might expect that someone with greater health literacy living in a more deprived neighborhood to be able to report better health outcomes than those with less health literacy living in a similar neighborhood. And so I think this might speak to in what context can individuals utilize their health literacy and translate that into better health. So if we're thinking about individuals who may unfortunately live in a more deprived neighborhood, even if they do show adequate health literacy and on the NVS and in our screeners, if they're in an environment where they're not able to access the resources that allow them to use this health literacy to improve their health, then we might not end up seeing that impact in our health outcomes as we measure them. And so this is thinking about health literacy at an individual level, but really expanding that view beyond the individual to look at the context of the individual. So thinking about health literacy not just as the individual ability to use these different health resources, but also what resources are available to them. I'm also thinking about health literacy at an organizational level. Abby touched on this in her presentation, but if individuals living in more deprived neighborhoods and the organizations around them might happen to be less health literate, then that might also result in this lack of moderation that we do see in these analyses. So just beginning to think about health literacy in a larger context, putting it in the context of structural factors and the environment of patients as we move forward. Wonderful. So just a thank you to the MidCog study team and my research team. My information is there, and I'm happy to take any questions at the end. I'm going to pass it off to Sophia.
All right. Let's see. Thank you both. All right. Perfect. Thank you, Abby and Brittany, for your presentations. I'm gonna continue on. I'm going to now introduce a brain health literacy framework that our team has been working on recently. All right, so I'm gonna start by going into a little bit of background of the significance of this. So in the United States, approximately 6.9 million adults are currently living with dementia, and this number is projected to double up to 14 million by 2050. So Alzheimer's disease is the most common cause of dementia, but there are several other known etiologies, including cerebrovascular disease, Lewy body disease, and frontotemporal lobar degeneration. And all of these different types of dementia can present with various different signs and symptoms. So there's, of course, memory loss. There's also difficulty with problem solving or completing tasks, confusion with time or place, challenges with speaking or writing, decreased judgment abilities, and also changes in mood or behavior. And at least prior to COVID, dementia was the 5th leading cause of death for older adults in the US. And it's also a major cause of disability and dependency, with major psychological and social impacts for individuals and their caregivers and their families. We also know that dementia is one of the costliest conditions to society. So out-of-pocket healthcare and long-term costs can be really burdensome for families impacted by dementia. And in addition to that, healthcare service utilization is higher because of things like injuries, accidents, infections, and other complications. So just in the year 2023, dementia cost the country $360 billion. And this may reach up to 1 trillion by 2050. And in addition, the economic burden is likely underestimated due to factors like non-medical costs for home safety modifications, adult daycare services, and also the indirect costs related to the impact of dementia on caregivers' health and well-being. So clearly, dementia has a major impact in our society and warrants a lot of attention. There's several known risk factors for dementia. Age is the single biggest risk factor. Prevalence of dementia increases exponentially with each decade over the age of 65. So while 5% of those between 65 and 74 present with dementia, that increases to 33% among those 85 and older. In addition to age, we know that genetics or a family history can increase risk. But importantly, there's now a rich body of evidence that really illuminates additional risk factors that are modifiable. So I'll go into more detail now. So the Lancet Commission has now identified 14 modifiable factors with sufficient evidence to demonstrate their role in the development of dementia. So as you can see here, those include education, head injury, air pollution, hearing impairment and vision impairment, hypertension and high cholesterol, diabetes and obesity, smoking and excessive alcohol consumption, physical inactivity, infrequent social contact, and depression. And it's really important to highlight that many of these are very tightly linked to social determinants of health, which of course Brittany was just talking about. And there are also really important dementia-related disparities. So we know that dementia impacts all sectors of the population, but currently historically marginalized or minoritized groups have a much greater likelihood of developing dementia. Our team's work recently has focused on the Latino population, and current evidence suggests that Latinos are 1.5 times more likely than white adults to develop dementia than non-Latino white adults. And I'll take a second to pause because I know there's a lot of different terms used for Latinos, Hispanics, Latinx, etc. I'm going to, for the purpose of this presentation, just keep saying Latinos to describe individuals of Latin American descent living in the US. So we know that there's this greater incidence among Latinos of dementia, and these disparities are expected to widen because the Latino population is expected to increase at the fastest rate over the coming decades compared to other ethnicities. So now going back to the social determinants that we've been talking about, we know that this higher prevalence of dementia is likely due to social determinants of health, including exposures to historic and continued marginalization and structural racism, and then the resulting environmental differences, including socioeconomic disparities. So these factors directly and indirectly impact things like where people can live, their exposures to psychosocial stressors and environmental conditions, and their access to education, employment, and healthcare. And then these factors in turn can have a detrimental downstream impact on health trajectories via multiple physiological and behavioral pathways, which can lead to the higher prevalence of those established risk factors for dementia that I mentioned earlier. And an important note also is that Latinos are the highest uninsured ethnic group in the US, which of course impacts their timely access to care and the availability of effective treatments. So given these disparities and also the significant psychosocial and financial impacts of dementia, it's important to find ways to promote brain health. So there's currently no definitive means by which to cure dementia, but there are a few new treatment options. And the most recently approved drugs are specifically indicated for people with either mild cognitive impairment or mild Alzheimer's disease, which really highlights the importance of early detection for improved prognosis. And then the lack of cure also highlights the importance of primary prevention. So it's actually estimated now that interventions that target lifestyle and health behaviors could delay or prevent up to half of the cases of dementia worldwide. As we have, or as I mentioned earlier, we also know that many of those known risk factors are a result of structural barriers. So of course, it's really critical to acknowledge the influence of these contributors and to avoid placing blame on the individual. But recently, the Lancet Commission highlighted that the most effective means of prevention will likely be a combination of government-level policy changes and also individually tailored interventions that focus on more directly modifiable factors. Also, the Lancet Commission has now highlighted that many of those risk factors for dementia do start appearing in midlife, and that their timely detection and effective management during this period can have a huge impact on health outcomes. And actually, you can see here in this figure from the study of Latinos, the investigation of neurocognitive aging, or SOL-INCA, that they specifically highlighted how many of the cardiovascular, behavioral, and lifestyle risk factors can manifest from early adulthood onwards. And they specifically call for focusing prevention efforts in midlife in an effort to address dementia disparities for Latinos. So it really does seem critical to focus on primary prevention earlier in the life course before that exponential increase in dementia risk in the decades after 65. So when I say brain health, I'm talking about the preservation of optimal cognitive function and in the absence of overt neurological disorders. We think that shifting to discussing brain health with a proactive health promotion focus rather than approaching dementia from an illness lens might help motivate and mobilize people to take action now and increase this sort of sense of personal efficacy and agency and combat the commonly held belief that dementia is inevitable. So limited health literacy in midlife could contribute to later life dementia. And this is because challenges in utilizing healthcare and accessing health information can contribute to adverse lifestyle and health behaviors, including alcohol use, smoking, sedentary behavior, social isolation, and poor sleep. And then engagement in unhealthy behaviors can lead to the development of chronic conditions, including hypertension, diabetes, and obesity, and their inadequate self-management, including treatment adherence, uncorrected vision and hearing deficits, and then overall worse physical and mental health. And for Latinos specifically, research has consistently identified disparities in many of these factors among Latino adults. And importantly, limited health literacy has often been shown to mediate these associations. And as Abby demonstrated earlier, our own MidCog cohort also has demonstrated that rates of health literacy and self-management skills are significantly lower in our Latino versus non-Latino white participants. So we know that many health literacy interventions have been effective for preventing other chronic conditions or increasing their optimal self-management. And health literacy interventions have also been successful for sustaining behavior changes related to things like smoking, diet, alcohol use, physical activity, and weight loss. So translating this to brain health, health literacy programs, or more specifically, brain health literacy programs, might help to increase dementia awareness, address misperceptions, and empower adults to take action now to reduce later life risk through lifestyle modification and healthcare engagement. So that brings us to our framework, which is based on an adapted model of the Pash-Orlow and Wolf health literacy model that Abby discussed earlier. So the brain health literacy model posits that limited brain health literacy throughout the lifespan, but especially in midlife, may lead to suboptimal healthcare use, insufficient protective behaviors, limited disease self-management, and ultimately increased risk of cognitive impairment and dementia in later life. And the framework is also informed by empowerment theory. So in the context of brain health literacy, a greater emphasis on a person's own ability to improve future health outcomes instead of a focus on dementia and a cataloging of personal risk factors might help to empower and activate individuals and lead to more protective behaviors. So while this model does include social determinants of health, psychosocial stressors, social and environmental factors, including things like acculturation, and system factors, including access and discrimination, the purple here highlights that brain health literacy and health activation, or a person's willingness to assume the role of managing their own health, could be potential mechanisms of empowerment. And importantly, the model includes both personal and organizational health literacy. So the ability to engage in healthcare and interact with providers and self-manage health can largely be determined by healthcare systems, so not just the individual alone. So the goal is really in identifying modifiable targets to address brain health, while of course still being very mindful of acknowledging the systemic factors at play. So we conducted several studies guided by this framework to explore middle-aged Latino adults' knowledge, beliefs, and perceptions and behaviors related to brain health and dementia. And it included a systematic review, a qualitative study, and a quantitative investigation. So some key takeaways from the systematic review and qualitative study were that there are remaining gaps in knowledge and awareness about dementia, including normative versus non-normative memory loss, signs and symptoms of dementia beyond memory loss, possible causes and courses of dementia, risk and protective factors, and treatment options. Participants also expressed how important a role things like familism and spirituality can play in the way that they conceptualize brain health and aging. And they discussed barriers to engaging in health behaviors and engaging and utilizing healthcare efficiently, including things like financial burden, family obligations, experiences of discrimination in the healthcare system, access and insurance limitations, and limited language concordant care. And in our quantitative survey of 200 English and Spanish speaking middle-aged Latinos, we found that 36% were very concerned about developing dementia. 61% believed there were actions that they could take to reduce risk, but only 29% could name at least one evidence-based measure that they could take to support brain health. So this really highlighted to us the opportunity for both increasing awareness of well-established evidence-based modifiable protective factors, and also for building motivation for behavior change. And I'll also just take a second to note that culture really stood out as a key piece of the model for us. So in our multivariable analyses, we found that more acculturated individuals were less likely to express concern about dementia and less likely to believe that steps could be taken to support brain health. And this is actually pretty consistent with existing literature about acculturation and really suggests the importance of increasing communication about the impact of and risk factors for dementia across diverse sectors of the Latino population, including first and second generation Latinos, and also generally across the lifespan. So informed by these studies, we expanded our brain health literacy model to include more of a health equity perspective. So as you can see here, we now add to our model factors like culture, community, familism, religion, racism and discrimination, and trust in the healthcare system. And as we've discussed, evidence suggests that Latino adults, as well as other minoritized groups, demonstrate lower health literacy and self-management skills compared to non-Latino whites. And various system factors and structural barriers might impede their ability to engage in recommended health behaviors or use the healthcare system effectively. So our goal is really to take an applied health services research perspective to leverage these pathways to address existing disparities by, first of all, empowering patients in midlife with requisite knowledge and skills for personal health and chronic condition self-management. And then second, identifying opportunities for reducing cognitive demands of health services to enhance patient engagement and, of course, take into account the various barriers to engagement. So in terms of future directions, the MidCog study will continue to monitor and interview the cohort every 2.5 years and continue to investigate these understudied modifiable patient and health system determinants of cognition, health outcomes, and later life dementia. Our second wave, our T2 or first follow-up assessment, is launching in 2025. And we actually recently submitted a supplement to expand our Latino cohort. We also know that the Latino population is extremely diverse, so there's definitely a need for further research looking at differences between these diverse cultural and linguistic subpopulations that fall under that Latino umbrella. And then also, as I mentioned, the Lancet Commission highlighted how the best approach to prevention is likely a combination of policy changes at the national and international government level, as well as individually tailored lifestyle interventions. So we also hope to leverage these findings in this framework to develop and implement a brain health literacy intervention for middle-aged Latinos. And ultimately, we are hoping that this framework and this work can be tailored and adapted for other minoritized communities. So thank you to everyone. And I'll now just kind of briefly summarize the overall panel that we had today. So we first learned from Abby that limited health literacy is prevalent in midlife and is equally detrimental to one's ability to self-manage their health as it is in later life. She also highlighted noted disparities in later life that are also now still present in midlife. We learned from Brittany that disparities in cognitive, physical, and emotional health outcomes are heavily driven by underlying socioeconomic and structural disparities. And her research on area deprivation index really highlights yet again how hard it is to untangle health literacy as a construct from socioeconomic position. And then also, finally, to address disparities in later life cognitive outcomes, including dementia, especially in Latinos, health literacy and specifically brain health literacy should be part of the public health agenda. So before we open this up to discussion, I'm gonna be asking a couple of questions to Brittany and Abby myself, but in the meantime, please feel free to drop some questions in the chat while I'm talking. So So I'm going to start with a question for Abby. So given the push for more studies focused on midlife, what are some factors to consider when researching this population?
Yeah, that's a great question. I would say that through working in a midlife study and helping with recruitment and data collection, a lot of the stressors that I was discussing and other Brittany and Sophia were talking about really do come into play. It really seems to present some unique challenges that it just seems to be a population that has a lot going on, has relatively busy lives. Like we mentioned, a lot of our participants work or take care of children or their own parents in that kind of sandwich generation, and have a lot of other responsibilities that research might not be highest on their list, understandably. So it's definitely we've learned and have an amazing team working on just a lot of flexibility. So having interviews in kind of different times that aren't during the workday, whether that be before or after work or even sometimes on the weekend, helping out with transportation. And then something that was done pretty early was just determining we couldn't have people here for like endless hours multiple times. So we just have them for the 2.5 hours in person. And that's a very short but very condensed and comprehensive interview. And then the rest of it is online over the phone for an hour. So I think that also helps with the flexibility. Um, and then, it's in the research context that we're having different challenges to get them here, but also I think it just parallels that busyness and trying to make sure that they have space and time to manage their health. And I think that's reflected in these unique challenges. So good question. Thanks, Sophia.
Great. Yeah, and let's see, Brittany, if you have anything to add to that as well, feel free to jump in. I know that you have also been working with these participants. But let's see, I would be curious, Brittany, if you could kind of speak a little bit to what you know about the association between health literacy and neighborhood deprivation.
Yeah, for sure. Great question. So we ran those analyses, even though I been thinking about it. So we found that people living in the most deprived neighborhoods were more likely to report low or limited health literacy. But part of why we hesitate to report that as a standalone outcome is that it doesn't necessarily seem like there should be something inherent in a neighborhood that might impact health literacy in terms of a mechanism for that. It could possibly go through other mechanisms like education or income, and how those might how a neighborhood might impact those, and how one's education and income might also impact the neighborhood that you do live in, and that in turn might then impact health literacy. But we just hesitate to report that outcome as a standalone factor because there doesn't seem to be an inherent mechanism linking health literacy and neighborhood deprivation. But definitely still thinking about health literacy in that context. And then even if you do know that people coming from a more deprived neighborhood might have a higher odds of reporting lower limited health literacy in like an organization where you might not have the capability to do that sort of screener right away, even just knowing the kind of neighborhood that a patient comes in might prompt you to be a little bit more supportive in the resources you provide or something like that, and kind of give a proxy in that way.
Yeah, that's really interesting. Thank you. I guess relatedly, would you be able to elaborate at all, Brittany, on like why health literacy didn't moderate the associations that we saw?
Yeah, for sure. And I think especially at a health literacy conference like this one, we're really thinking about health literacy as a tool for prevention or a tool for intervention. And so, I mean, at first, hearing that health literacy does not moderate this association, it would be a very nice intervention factor that, oh, if we improve people's health literacy, then even if they're living in a more deprived neighborhood, we can impact their health in that manner. But I think just speaking towards having a general context of the people and the patients we work with. So even if we are empowering people to help improve their health literacy or providing education on that front, even just being cognizant of the environment in which they operate, such that they have the resources to be able to adequately use that health literacy and actually transform that into health behaviors and like health activation and those different self-management skills that Abby was talking about. Having the resources to even do that, even if they have the health literacy to do it, is, I think, the big factor there.
Great, thank you. And yeah, I want to again just encourage anyone to add a question to the Q&A. I see a couple here. I'm going to ask Abby one more of my questions, and then I'll start turning over to the Q&A section. So yeah, Abby, one more question for you. Of the sort of health activation components that we can think about, why are you interested in this focus on health self-management specifically in middle-aged adults?
Yeah, great question. Yeah, looking at the 3 different pathways, it feels like we could utilize all of them. And I think for me, how we've contextualized it with health self-management is it's really just like a slight step beyond health literacy that's a little bit more putting health literacy into practice. So things like being able to properly understand a medication label and dose it out properly over the course of the day. It's getting a little bit closer to those individualized steps, as Brittany and Sophia mentioned, and really was able to show us that there are a lot of systemic organizational concerns with health literacy that need to be addressed. But if we're thinking of kind of like these short-term interventions or points that we can target, I feel like trying to use more like tangible ways to empower people in their own health, and especially with something that can really look like helping people figure out how to implement these practices into their busy schedule in midlife is something that feels more achievable in the short term. So that's kind of my interest in the health self-management piece.
Awesome. Thank you, Abby. All right, great. So I've got a couple questions here that I'm going to pose to the panelists. So the first question is, 35-year-olds are at a very different stage of life than 60 to 64-year-olds. So does anyone have any plans for analyzing the data according to age by decades?
Yeah, that's a great question. And I think it's something we also have talked about. So I have not ran my analyses specifically by decade, but something that I did look at, because I did have this question of, does health literacy and health self-management change over time? And what I was able to do is combine the MidCog data with our older cohort data, the LitCog study, and just cross-sectionally see, putting people into categories by decade, whether or not cross-sectionally there was an increase or decrease in health literacy. And what we found actually was it was pretty consistent across all of the buckets. And this ranged from 35 to 85 when we added that LitCog group. And that was for both health literacy and health self-management. So of course, I'd be really intrigued, and we'll definitely run these analyses about these relationships and the sociodemographic factors that contribute on by decade, but just seeing from our at least cross-sectional data, we've seen that it stays relatively the same.
Awesome, that's really interesting. Thank you for sharing that. Brittany, what about you?
Yeah, I think that is a good point, and that obviously 35-year-olds are experiencing a different set of life stressors than people who are 62 or something like that. I will say, just as we're finishing up recruitment and getting final numbers on the age distribution within our midlife cohort, this is definitely an analysis that we would run probably once we have that a little bit more settled, as those numbers are still a little bit in flux as we're finishing up recruitment, but definitely something to consider going into the future analyses.
Yeah. Yeah, I think that it's a really good point. That's a huge age range. And so it's kind of tough to just talk about this like monolith age group as if it were all the same. So I think that's a really important suggestion. I know it's also always kind of an interesting point of contention when people ask what the age range is that we're including in midlife. And there's like different arguments, especially about that starting point. But typically in sort of lifespan developmental work, we think of early adulthood as going up till about age 34. So that's sort of why we have chosen 35 as the starting point. But yeah, it's a huge range. And so I agree. I think that that's a really salient point. Let's see. We've got one other question here. The question is if our institution flags patients as low health literacy in the EHR for providers based off of like the NBS scores that we were discussing. And then if so, are there any interventions that we're having our clinics implement regarding low health literacy communication? So I'm not sure if either of you knows the answer to this at this point.
So currently our study is not we are not working with primary care and giving them these results just for, I think, the way that we've set up our study. It's not providing information to the practitioners. But I will say that I think that this high of a percentage really shows and supports the emphasis on maybe trying to screen more for health literacy at Northwestern and in hospitals and in primary care. So I think we are currently not doing that, but I think it opens up the conversation.
Yeah, and I know that our team has worked on several other studies that are investigating sort of more pragmatic interventions for how we can lower some of this system level burden for people. So thinking more on like the organizational health literacy side of things. So I know we've done certain studies looking at, for example, medication labels and things like that. I don't know if Brittany or Abby, if you have anything to add in terms of some of the work our team has done, but yeah, I think overall that right now we're in the collection stage for a lot of this and hoping to leverage this going forward. Yeah, any other questions for our team here? And I think if anyone wants to raise their hand, I think we will also have that function. Okay, so we've got another question. I'll start by asking Abby to answer this one. If you were to do your research differently, do you have any ideas of what you would do?
That's a really good question. I think something I would maybe add also is we do have some mental health factors and outcomes that we look at, but I have a particular interest in depressive symptomatology as well. And so I think for my own intrigue, I'd be interested to see if there's any relationships between specific symptomatology of depression and how it relates to people's, not just their health literacy and health self-management, but also their activation, their desire to implement these practices. So I think just from a personal intrigue, I would add that.
Brittany, what about you? Anything that you would have done differently with your study?
Yeah, good question. Our study doesn't have the data for this yet, but kind of taking a life course perspective of neighborhood deprivation in context. So, whereas right now we have a kind of a cross-sectional measure of where they currently live and the neighborhood deprivation in that, but that doesn't tell a story, the patient's life story. And so, it might be possible that health literacy does come into play if we're considering the patient's whole life course, whereas in this one section, the slice taken in midlife, that you can't see that association. So I'd be interested in just kind of zooming out and getting even a broader view.
Awesome. Yeah, and I think in terms of my own work, a lot of what I was doing was, as I mentioned, for my dissertation. So I think there's a lot of kind of limitations that comes with that, in terms of not having a lot of funding and trying to get things done quickly. I think that in an ideal world, some of the recruitment that I engaged in was more of convenience sampling and using a mixture of different recruitment methods, including like recruiting people from our team's existing studies and our clinics, and also from like social media. And I think in an ideal world, I would really want to do a lot more kind of community-based research and spend a lot more time building relationships and partnerships, which is, something that I've done in previous, previous research, but for this one, it was sort of more of a convenience-based recruitment process. And so I think that there's, in terms of especially working with members of historically marginalized communities, we definitely know how much of how important it is to really build those relationships and build up trust, especially as I talked about how, mistrust or trust in the healthcare system and discrimination all are really important factors in everyone's experiences. All right, any other questions? Okay. Well, if not, I think we can maybe wrap this up early, give you a couple of free minutes. But we really thank you all for coming and joining our panel, and we hope that it was valuable for all of you. Thank you so much.